Okay, it looks like it's time for us to get started, and I want to thank you everyone again for being here, and thanks for those who are saying hello in the chat, and we would love to encourage people to comment or send us any questions in the chat throughout, so please continue to do that. And this is our Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today Sean Bear is going to be presenting on treatment knowledge. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the TTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification exams, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Our center is a NADAC certified educational provider, and CEUs are available for request for a $15 fee. The request form is available in the files pod in the webinar screen, and we'll also be sending this out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. I'm sorry, it's actually a chat pod. It's a little bit different. So it shows, everybody can see the name that you entered when you registered, so just be aware of that. You can actually, on the top of the chat pod, the little menu bar, if you select Start Chat With, you can send something privately to hosts, presenters. If you see someone's name specifically, you can do that too. So feel free, if you want to send something anonymously, to send something to hosts or presenters. That would work best. Today's speaker is Sean Bear. Sean is a member of the Meskwaki tribe in Tama, Iowa, and he's the co-director of our National American Indian and Alaska Native Technology Transfer Centers. He's been working with Native Americans with substance use issues for many years and uses his passion in this work to help others return to the spiritual ways of their ancestors. So I want to pass things over to Sean now, and we'll get started, and thanks again for being here with us.
Okay, hello everyone. This is Sean Bear. I think some of you might have heard from me before, or did some of the webinars with me. I think we were going to have somebody else present, but I think they couldn't do it today. So please bear with me. So what you're looking at is the training objectives. One is to gain a better understanding of evidence-based practices, best practices, and promising practices. Also to gain a better understanding of the importance of the treatment alliance. Become familiar with commonly used evidence-based and best practices approach. And better understand co-occurring disorders and integrated care. And then to also explore medication-assisted treatment. Okay, so as we'll move forward with this, so you see that here it begins with evidence-based practices, and it goes on to best practices and promising practices. So with evidence-based practices, normally these are the methods or techniques that are used. It's the use of current best evidence in making decisions for the care of our parents, our patients or clients. Remembering that the work we do is for the betterment of the client, and that we need to be able to work for the betterment of our clients in change and things that'll help them even better. Best practices is a method or a technique that has consistently shown results superior to those achieved by other means. So in a sense, it's considered the best methods in practice through experience with clients or patients. Promising practices, it's an intervention or strategy that shows potential to become a best practice or early stages of becoming the possibility of becoming an evidence-based practices after further research. You see, some of this has to do with research and how long it's been out there, how the success is for each. So, think about it. If you're looking at many of the evidence-based practices within SAMHSA, they have lists of evidence-based practices, but they also now have a list for those evidence-based practices that work with natives. There's not that many, but there are those that are considered best practices or promising practices. Some of the youth things they do down in the Southwest, a lot of these were promising practices. Best practices, as we know, is utilizing the culture, things within our programs and the way that we work with therapy at counseling. Okay, so the American Society of Addiction Medicine, if you're utilizing the ASAM, they do have the third edition, describes the characteristics of addiction. Now, if you're looking at this, there's more to it, but this is a smaller kind of a definition of it. So it says an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behavior and interpersonal relationships, and a dysfunctional emotional response. Now, if you're looking at this, there are other parts that go with this. That go with primary chronic disease of the brain reward system, motivation, memory, and related circuitry. So if you're going with circuitry, you're also involving the chemical things that are going on with the brain. Normally what happens when somebody puts a chemical into their system, the body is going to react. So many times with substances, you have serotonin and dopamine that is being released. And our body, looking at these, are big in rewards with dopamine and serotonin. Dopamine makes you feel really good. Serotonin a lot of times have to do with mood. So because these are part of the reward system, and especially looking at youth or teenagers, things like that, they are very motivated by rewards during that time. If you look at many of the youth things going on now today and what they are talking about with this system is that they don't always have the control, in a sense, to control all their emotions. They're going through a lot of chemical changes, a lot of different chemicals are activating, or things like that for change within the body. Now, even if you're looking at just alcohol itself, or marijuana, or let's say methamphetamines, the way that they release dopamine and serotonin is at different levels. So when a youth uses substances, a lot of it is going to be activating the reward system of the brain, which wants, let me see. So with pleasure and things like that, so it kind of becomes a habit. Well, over time, when people are using substances, and many of these substances are being released within the body, the way that your brain kind of works is it wants things to be able to be balanced. If a certain chemical raises too high, the body kind of readjusts. It wants it to go lower. So as time goes on and people keep utilizing substances which activate some of these other chemicals within the body, the brain is going to keep adjusting. So by the time they come off the drug, at the very end, maybe we see them in treatment, what happens is their levels are going to not be the same as somebody else who had never taken substances before. Of course, we're going to have the cravings. Of course, we're going to have withdrawal symptoms. So normally what happens is the withdrawal symptoms are usually the reverse of how the substance made them feel. So if it's an upper or something like that, they're going to be feeling low. If it's a downer, of course, they're going to be feeling more manic. So that's alcohol is a depressant. So when people are going through withdrawals, everything's going to speed up. When they're using like a methamphetamine, an upper, when they come down, everything's going to go a little bit more for depression, if you're looking at that. So like chronic disease, it may often involve relapse or remission. Without proper treatment and or engagement and recovery, it may progress further. Okay, so let's see. Individual, family, community recovery-oriented systems of care. Okay, first, to properly assess the client using multi-dimensional tools. So normally when we're in a substance abuse agency, you will begin to assess them right away. Small kind of inventories or something like that to be able to test and see if they meet requirements to further the assessment and possibly into treatment. Okay, so to provide integrated, coordinated, longitudinal care using evidence-based approaches. To provide an optimum opportunity for healthy behavior change through the Therapeutic Alliance. Remember, with that, you're also building rapport with the client. To improve the client's overall health and wellness. To measure the outcomes, and to provide informed consent. So normally when a client is admitted into the program, we're going to make sure that they are informed of the confidentiality and consent forms and everything else that's needed for treatment. Now, to measure outcomes, a lot of times as you're looking at outcomes later on, normally with funding and stuff like that, how the client is are when they graduate and further on. Are they going to keep abstaining from substances? If you're looking at to improve the client's overall health and wellness, of course, if you're working with more of a native clientele, we're not just looking at just the health and wellness aspect of how normally many people see it as. We would be looking at it more of a holistic manner, whether the physical, mental, emotional, and spiritual parts of this. To provide an optimum opportunity for health behavior change through the Therapeutic Alliance. So that has partly to do with building a relationship with the client and to work towards behavioral change. Some of you might be using cognitive behavioral therapy to be able to get the client to think a little bit differently in order to change that behavior. Looking at evidence-based practices, it can be a little difficult when you're working with natives because not all of these evidence-based practices have been tested with native communities. Okay, so what does this all mean? We have a responsibility to improve service delivery and monitor client outcomes. So it's part of our job, in a sense, to advocate for the client, in a sense, to write papers, to move towards a change for the clients that we serve. The field of addiction treatment is evolving and will require a broader understanding of the term treatment. Okay, we have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. So a lot of times what we want to be able to do is to stay on top of many of the different practices that are out there in counseling, therapy, if we're working with natives, possibly equine therapy, the ropes courses, the canoeing, a lot of these things that work with natives. Also, that might include like healing or culture, belief systems. Okay, those in leadership positions have a responsibility to prepare and mentor the next generation of addiction professionals. Now, it's, if we look at many things in our life, more from a cultural point of view, is that in a sense we're being groomed for life. Our parents, our grandparents raise us to be able to be good people, to do things, to treat elders respectfully, to knowing different things within our lives that we need to understand within the culture, within the tribe, within the peoples. But also, if we're looking at ourselves in a leadership position, we also need to make sure that we are preparing those working under us to be able to utilize the services that we know about and the practices and everything that works the best for our clients, so that the clients get the best care possible. I think I was pretty lucky in having my first supervisors and director and stuff that I had when I began counseling, is because there was many different factors that was needed. Over time, we were, knowing about not just what's in treatment, but also professionalism, ethics. There's a lot of different things to be able to look at. And if you're looking at the 42 CFR, well, some don't really like this 42 CFR, but many of these are based upon actual court cases that have happened. So ethics, in a sense, is to protect the profession. We need to be able to follow those advice and the rules and stuff like that, so we ourselves don't get in trouble. Okay, therapeutic relationships. Okay, so in building a therapeutic relationship, it's an improvement of success, of the chances for successful outcomes. We're looking at our clientele, patients and stuff like that, and looking for the improvement of their chances for successful outcomes. What is going to be happening after they leave treatment? We need to prepare them, just like even like parents or coaches and things like that prepare people for the field. When they're going to be going out into the world, when they're going to be going out onto the ball court or football field or whatever it might be, so they know what to do when they're there. So it can't just think about just treatment itself, but looking at beyond that. What are they going to need? Are they going to need some kind of other support from the the counselors, the therapists that'll help them to be able to be successful later on? Are we providing them with the training that is needed that will help them more with preventative skills, prevention, to be able to help them so that they know how to react when somebody asks them if they want a drink or something like that? A lot of times rehearsal is good for that. That way they don't have to plan on the spot what they're going to say. It's already set. They know what to say before that ever happens. So also looking at the therapeutic alliance, the personality of the therapist or counselor can play a large role in developing a rapport. So we're going to be looking at how we look at the goals that we are making together for that treatment. Looking at safety and trust, remembering that providing too much information can also be hurtful. Remembering our ethical responsibilities and the boundaries that go along with those. And remembering power distribution. So then the counselor is always one in the more of the power, more of power within the counseling relationship. Okay, so therapeutic relationship, the function of it, positive reinforcement, encouragement, instill hope, build efficacy. So with positive reinforcement, looking at that, people like to hear how well they're doing. We all want to have people who are building us up and not tearing us down. We should be providing the client with support and accurate, genuine empathy. One thing that goes along with that is remembering that within counseling treatment is empathy, not sympathy. So there is a definite difference with that. Empathy has more to be able to feel what the person is going through, in a sense. Sympathy is just feeling sorry for them. We want to be able to have empathy, not sympathy. In partnership with our client, develop goals that are realistic, attainable, and adaptable. Do not set them up for failure. We want them to be able to meet these goals. Model adaptive interpersonal functioning. So a lot of times we are not just the counselor, but we're also the model. We're the mentor. We're somebody who maybe they want to be like. And we need to remember that. So, therapeutic relationship and client development. We want the client to be able to feel heard, understood, accepted, respected, and empowered. We need to be able to believe in our clients, to be able to show them that they are heard, by showing that with either words or with behavior. We want them to feel understood. So a lot of times we might ask a question, do you mean this or this? So then when they are able to say yes, then they realize that we are understanding what they're saying. We want them to feel accepted, respected, and empowered. They want to be able to feel that the therapist is concerned, feels the therapist is working with him or her, feels the therapist is realistically optimistic, feels and recognizes that positive change is possible and or occurring. This requires good listening skills, as people want to feel that the counselors and therapists care. Okay, so the American Society of Addiction Medicine, the ASAM again, the criteria for that is clinically driven, not program driven. So with that, our focus should be on the welfare of our clientele or patients. Criteria do not involve a prescribed length of stay, but to promote a flexible continuum of care. So a lot of times we're going by the client themselves. So sometimes we may want or have like a time frame or something like that when or a length of care when clients should be okay. But if they need further training or further treatment for that, it's good to be able to add that in there. Maybe that'll be part of the treatment plan. Include informed consent. So that should be right at the very beginning. We need to make sure that they're fully informed of their consent and confidentiality, and make sure that they understand that. Are outcome driven. Outcomes for client patient success are important in evaluating our own programs and how we do. Clarify medical necessity. So what does medical necessity mean? So we need to be able to clarify that to the clientele so they understand what that is and what we can provide. Okay. More of the dimensions of the ASAM is acute intoxication and withdrawal potential, biomedical conditions and implications, emotional behavior or cognitive conditions and implications, readiness to change, relapse, continued use or continued problem potentials, recovery living environment. So if we're looking at that, acute intoxication and withdrawal potential. So is the intoxication withdrawal, is it something that just came on? Are they intoxicated or are they going through withdrawal? With that, they might be able, if they're going through withdrawal symptoms, they might need detox. So how are they going to be doing for treatment? Are they ready for treatment, or they need further time for detoxification? Biomedical conditions and complications. Are there medical things that we need to be aware of before they can be admitted into treatment? Emotional, behavioral, cognitive conditions and complications. Are there any kind of diagnoses or anything like that we need to be aware of before we admit them? Is it gonna be workable within the treatment? Readiness to change. How ready are they? So we're going to be looking at Prochaska and DiClemente in stages of change and where they're at. Relapse, continued use, or continued problem potential. So do they have a history of relapse? How long have they been using? It goes also along with recovery or living environment. Are they living with people who are still using? Do they have a place that they can stay that is clear of alcohol or drugs? Okay, whole person, client-centered care. From start to finish, their therapeutic alliance is paramount. Tribes are good examples of using recovery-oriented systems of care, as many tribal members and programs can be utilized, such as healers, medicine peoples, traditional people, the elders who may assist in helping clientele and becoming more connected to culture and practice. As we look at many of our clientele who are native, normally the first thing that goes is the spirituality. We look at them, many times what happens is that when they begin to use, they may stop going to ceremonies. They may stop going to some of these events where they are needed to be clean and sober. And what happens then is people begin to ask them, hey, where were you? What are you doing? How come you weren't at this ceremony? Normally you were there. Well, they begin to back off away from that then. They move out of there. Later on, people may see them in the community, say, hey, where you been? I haven't seen you. When are you going to come back to the ceremonies or something like that? So what you're doing then is not just from the spirituality aspect, you're moving then into community. They're beginning to isolate themselves. Further on is then when maybe their family isn't seeing them. They begin to stay away from certain family members, and then finally they're kind of isolating. So also then you're looking at grief issues. They might want to get back to the treatment. They might want to get back into the ceremonies and stuff like that. So a lot of times we need to be able to look at that. What is going to be going on within our treatment plans? So proper treatment requires proper assessment. Multidisciplinary team approach using common community support systems. So that's very good with the recovery-oriented assistive care. What else is needed? We have wellness centers, we have tribal courts, we have our elders or healers, those who are running sweat lodges or other ceremonies that might be helpful. Selecting a particular therapeutic approach that is most likely to result in the client's improved health. Now, remembering that not all evidence-based practices work or have been studies with natives. So when we look at that, even though they are evidence-based to other races or something like that, they might not really be scientifically or evidence-based to the tribal communities. Okay, then we move into theory. We have behavioral theories such as Skinner, cognitive behavioral therapy such as Beck. You may have seen what the depression inventory, Beck's depression inventory. Contingency management incentives, screening, brief intervention, referral to treatment. You might have seen that as Esbert. Rationally motive behavioral theory by Ellis. They also have rationally motive therapy. Motivational interview by Bill Miller. Stages of change or trans-theoretical model, such as De Clemente, and medication-assisted therapy. Okay, so I believe we're going to be going through some of those individually. Okay, so remembering that 1 ounce of behavioral change is worth 10,000 pounds of insight. Remembering that it's not a race. Any change toward the goal is good. Small steps in life, if we're looking at culture, traditional teachings and stuff, it takes a while to understand how things work and what we need. It only makes sense that treatment would be the same or change itself. So looking at some constructs, remembering with the behavioral theory is that behavior is learned, therefore it can be unlearned. New behaviors can replace old ones. Focus on the observable, how people act. If you're looking at behavior or behavioral theory, they focus on what they can see. So a lot of times that's the only thing that we can go by is what we see, not by gossip or anything like that. Less interested in cognitive emotional states. Believe that behavior represents learned habits. So a lot of times we're looking at habits. It comes from behavioral theory. So habits. If we're looking at habits, and we're looking at change. Change is difficult and stressful, even if it is good. If you're looking at like marriage, Sometimes even marriage or anniversaries or things like that can be stressful. So what I'd like to be able to talk to you here about is that to look at change a little bit differently. Okay, so you walk in with a client, either that or you can think about it yourself. But if you were to look at this screen and take out a piece of paper, and now if you're right-handed, you want to use your left hand. If you're left-handed, you want to use your right hand. Okay, so looking at that as an example, you write down what is written on the screen or a whiteboard that you might have on a whiteboard or something like that for your clientele. Now, say this is part of how my supervisor evaluates the counselors, and it's really due in just a couple minutes. So please, can you fill this out? You have to use your non-dominant hand. Now, okay, so you might give them a minute. Of course, you'd want to have something longer than this. So then you'd kind of say, okay, can you please hurry? I really got to get this in. I'm really getting worried about this. The supervisor wanted this before I ever came to this session right here. So could you please hurry? A little bit later it says, okay, you're getting really rushed. So, okay, I don't care how you finish this. Just finish it, please. And then I'm going to hurry up and take these papers and give them my supervisor. Normally what you will see is that most people, when they are rushed or stressed, they will go back to what they know the best. So many people may move to their dominant hand and finish writing it. Now, if we look at our clientele, many times they have been coming off of substances, and what they have been done before is it might have been habit to be able to use a substance when they're stressed, to smoke a cigarette when they're stressed. To them, that works. So what we're doing is asking them to do these things in a stressful environment and change without that. So if we're looking at that, we cannot expect our clients to be at the same level we are. And that's something we need to be able to look at and to be able to understand when we're working with our clients. Okay, so behavioral theory, conditioning. Looking at classical conditioning refers to the association between a stimulus and an involuntary or automatic response. So cravings can be a conditioned response triggered by stimuli that the client may or may not be conscious of. So a lot of that comes from Pavlov. You remember Pavlov dog, the little boy. Well, no, what's it? Yeah. So then we also have operant conditioning. Refers to an association between a voluntary behavior and a consequence. And that was done by Skinner. The nature of the consequence will impact whether the behavior occurs again. So, legal, health-related consequences. If something bad happens afterwards, they may likely not do it again. Okay, so we go motivational incentives equals a contingency management, providing reinforcement for healthy behavior. Promoting awareness of motivational incentives is based on the positive research outcomes and lessons learned from the National Institute on Drug Abuse, NIDA, Clinical Trials Network, CTN, study entitled Motivational Incentives for Enhanced Drug Abuse Recovery. Now, if you look at many things, you're looking at kind of like a token economy, which also comes from classical conditioning. Okay, so cognitive behavioral therapy or theory, cognitive behavioral therapy, cognitive behavioral CBT combines behavioral therapy, helps to weaken the connections between troublesome situations and the reaction to them. Cognitive therapy teaches you how certain thinking patterns or feelings impact our behavior. Very simply put, cognitive behavioral therapy attempts to help patients recognize, avoid, and cope. So a lot of times we need to be able to work with our clientele, give them good coping mechanisms, prevention, things like that. So a lot of times our clients may present with feeling guilty, feeling sad or bad, remembering though, but to utilize the language appropriately is like, they're not a bad person, they just made bad choices. So in combining with the cognitive behavioral theory is looking at cognition as a way to change behavior. Okay, so relapse prevention, part of cognitive behavioral therapy, is identify high-risk situations. You know, are they still hanging around people who are using? Are they still going to some of these risky places that where they used to use? If you're looking at that with cognition, certain places may trigger a response for cravings. Certain people may do the same thing. Coping skills training, that might be to how they look at that. Maybe they're going to drink orange juice. Maybe they're going to drink something else, a pop or something like that, or to stay away from those places and people. Enhance self-efficacy, to be able to let them know that they're doing a good job. Help them to good self-talk. Relax reframed as teachable moments. That's something that I like to always look at when there is a relapse or a lapse or something like that, something small. When they come in, they're feeling bad about maybe a lapse or relapse, and that is a good time to look at teachable moments, times that they're able to listen. Challenge positive alcohol expectancies. So if we're looking at the person says, let's say it helps them when they're sad. Well, I know in my background, I've seen many clients say that it makes them feel better. But when they begin to use, they begin to cry. Thinking about people they've lost in the past or something like that. But that's usually then when you kind of challenge that. So it's not always going to be good. And by the time they wake up, they may have woken up in jail or in more trouble. Okay, lifestyle balance. What are they going to be doing? It cannot just be partying, but they also need to be able to eat right. They need to be able to get exercise, to be able to have healthy communication with the community members and their family. Okay, in a nutshell, rational emotive behavioral therapy, our theory. Something happens to the client. Client has a rational belief about the situation. Client has an emotional reaction to the belief. Therapists help the client recognize errors in thinking that led to the irrational belief and find alternative ways of thinking about the event. For example, I was only arrested for drunk driving because that cop has it out for me. Well, and I've heard clients say something like that, or they were being racist, discrimination, or something like that. But maybe they were stopped in a car with 7 other people in a little bitty car. Well, maybe that was at 3 o'clock in the morning or something like that. Well, if you have 8 people in a little bitty car, it doesn't look really good anyway. It does look like something could be going on. But if you're looking at this from breaking habits, something happens to the client. But if you're looking, and this is where you're going to be looking at the ABCs normally, is that A is an antecedent, B is for behavior, and C is the consequences. So the consequences of this is that they got arrested for drunk driving. Part of the consequences is also their emotional reactions afterwards. Do they feel guilty? The behavior may have been using. The antecedent could have been hanging out with certain friends, or something like that. Because normally what happens is looking at the behaviors and thoughts, feelings, emotions, and stuff that before the antecedent ever came about, and how they felt about this. So breaking it down a little bit is that maybe they were thinking about going to the bowling alley with some friends. Maybe they were going to go do something with family, but then they met some other friends, and they talked about, maybe how good it was going to be, or thinking about the past, or something like that. They got them to go out to drinking or something like that. Well, maybe part of that drinking made them feel better, but after they got caught for using substances or drunk driving, is that then there became more guilt. So a lot of times you're looking at the consequences of the action, because if they had never got caught, they might think they did good, and they actually could take that as a positive thing. So, but in looking at that, in this case, it was negative. But it's even negative just because they used, especially if they're in treatment. Okay, so stages of change, we're looking at Prochaska and DiClemente. The stages of change: pre-contemplation, contemplation, preparation, action, maintenance, relapse, and recycle. So pre-contemplation is that they may not know there's a problem with their substance use. Contemplation, they're looking at things that are going on. Maybe they're thinking about going to treatment. Preparation is when they are actually preparing themselves for treatment. And action is when they're in treatment. So maintenance, action is part of the treatment as well, but then maintenance can go further on. What are they going to be doing to help keep themselves clean and sober? Relapse, there may be a relapse. It doesn't mean there's going to have to be, but normally then there's a recycle. Something happens and they get back in the treatment and start back on that road again. Of course, there is motivational interviewing. Motivational interviewing works very well with Native communities. There's a lot of different information that people don't realize with motivational interviewing is that during that time, Bill Miller was working with tribes down in the Southwest, but by you changing the way that he was speaking with the clients, began to be able to see what works and doesn't. Of course, with the cultures, can be a little bit different, but in a sense, after that is when he kind of wrote about motivational interviewing and what he learned. Very interesting. Okay, so fundamental approach is collaboration with the client, evoking responses, autonomy, remembering that the client has autonomy or self-rule. 4 principles that express empathy. Develop discrepancies in what the client is saying. So if they say it doesn't make them sad, but later on then they're crying, there's a discrepancy. This could also be within assessment approaches. Does alcohol ever cause you any problems with others? They may say no. Later on it says, well, comes out that maybe they get in arguments with their spouse or something like that. So there's a discrepancy. Roll with resistance. Just don't keep hammering on any kind of resistance, but work through that with the client. Support self-efficacy. Helping them to make changes, but remembering they do have some choice within that. Okay, clinicians commonly think they already practice motivational interviewing, though it's often not the case. Okay, what makes motivational interviewing a unique communication approach is how its constructs are employed by the clinician. Motivational interviewing requires attention to timing, specific strategies, application methods, and maximizing the effectiveness of these skills. So if you're looking at timing issues, sometimes you want to be able to bring these elements of what is going on within motivational interviewing at the right times. Specific strategies, making sure that you're using open questions, not closed. Application methods and how you're going to go about that. Maximizing the effectiveness of these skills. So over time, in practicing these skills, you begin to be able to find the right timing and how to utilize that with your clients. There are some that are actually right now developing a native motivational interviewing. There are some out there already, but I know that there are some more coming out because there was the new motivational interviewing that came out. Okay, ESPRT, screening. ESAS for screening tool is used to assess client risk of having a substance use disorder. Brief intervention consists of a 3 to 5 minute motivational discussion with the client concerning the screening results. Referral to a specific resource and additional assessment and/or treatment service. T is treatment provider. Process should allow for the warm handoff from referral source to a treatment provider. Also, the soft handoff many times may be utilized even before that, because as a nurse or something is utilizing this within the health clinic or something like that, there may be things that come about within the health assessment that may lead to substance use, and after a small talk, they may bring in a doctor to be able to talk to them. So remember, it's also a warm handoff then as well. And then part of the warm handoff further on is to be able to meet a counselor that they might be able to speak to later. Okay, other theories worth mentioning. Social cognitive theory, personal factors, environmental influences, behavioral continually interact. People learn from their own experiences and from observing the the actions of others. Health belief model helps to explain why people do or do not use preventative services, has to do with perception of rewards and risks. Social ecological model takes on the account multiple influence on behavior and states that behavior both shape and are shaped by the social environment. So if you're looking at the social, in a sense, theories, they're based upon, social models. They're looking at how people interact with each other and how the social environment changes us as well. Also, if you're looking at cognition, you're going to be looking at schemas. So schemas, in a sense, are have to do with like certain kind of situations. So we learn in our lives that around certain situations, this is how you act, this is what you do. Later on, these may go further out into other areas. So sometimes we may need to be able to look at that. Okay, so it looks like we have, 4 minutes left. Are there any questions or comments? Kate?
Yeah, thanks everyone. It looks like people have been sharing who they are, where they're coming from. So thanks so much for letting us know about that. It's great to see all the different regions that we have represented by people who are attending. So thanks so much for sharing that. So there's a little question here. So opioids are mostly downers, not uppers. Can you respond to that one, Sean?
Opioids. Well, to look at opioids, we also need to look at why they're using these opioids. Is it for pain? So if we're looking at the pain kind of situations and how they affect the body, over time by using opioids in order for pain, what happens is that with pain itself, the pain becomes more sensitive. They are more sensitive to pain. By the time they come off of an opioid, they are more sensitive to it. They are more sensitive to the pains they feel. Most people, I know that some counselors believe that, it's just in their head, they're not having pain, but really they are having pain. It's just at a different way of experiencing that pain than is what is normal. Hope that answers the question.
I'm not sure, but I was wondering if she might be asking about ones that are, the language is escaping me, but some drugs will cause you to relax, and then other drugs will give you energy. So I don't know if that's part of what she was, I don't know what this person was referring to. Do you know which of those opioids tend to fall under, Sean?
Many of the opioids are, they're utilized for pain as painkillers. I think sometimes they're also mixed, though. They're not always just a downer, but the way that they're utilized can be both. I mean, it just depends on what these people are utilizing, but many times the opioids are used for pain. There are some that might have a stimulant that speeds up the body. Some of them might have depressants that help to slow things down. It just depends on what kind of opioids they're utilizing.
Okay, then, yeah, I think that,
There are different kinds of painkillers. So some may affect the area right on the spot, but some may also stop certain substances or certain chemicals from being released, so they don't um, feel it that way. It just depends on what kind of opioids they're utilizing.
great, thank you. It looks like some other people are typing in some questions or comments, so I'll give you a few minutes to do that yet. But before we close out, I just want to remind everyone that this session is being recorded, and we will send out a link in the next couple of days to the recording so you can view it again. And you can share it with colleagues, and it also will include handouts of the slides, so you can use that to review. If you're working on studying for your licensure, hopefully this will provide some of that, but let us know if you have questions, if you have areas in particular that you are hoping we'll cover. This is part of a series. We'll be doing it throughout the year, but if you have particular questions that you're wondering about in relation to drug and alcohol licensure, we'd love to hear from you and get your thoughts. And then I'll just remind everyone too that as we close out, we'll have a short survey that we would love you to take a couple minutes to go through, just to let us know what you thought of today's session. So thanks in advance for doing that. Okay, so a couple of people are asking again, just to clarify, if opioids are considered a depressant versus a stimulant, in addition to blocking pain, or are they, where are they on that spectrum? Are they considered one or the other? Sean, do you know?
When it comes to opioids, I think with this you're looking at something a little bit different. Whether you're looking at it as a depressant or a stimulant is not really the answer. It has to do with the withdrawal symptoms, because those is where you're looking into danger.
Okay, so thanks, Cindy, for that comment on having a training on pain and pain management. And just so you know, next week, as a part of our opioid specific grant, we are having a webinar on Thursday at 1 p.m. Central. And so that I'll make sure that has gone out to all of our lists, but that is going to be specifically on medication assisted treatment. So if you're interested in that, watch for that for Thursday, and we'll I'll make sure that went to all of our listservs. But with that, if we don't have any other questions, I think we'll finish up. And once again, I just want to thank everybody for joining us, and thank you so much, Sean, for sharing your knowledge and expertise in treatment. And we look forward to being with everybody again in our other webinars more frequently. We'll be having one a week now, given our different projects going on. But hopefully you join us next time. Thanks so much.